Hi, I'm Matt Reed and I'm a consultant in emergency medicine at the Royal Infirmary of Edinburgh. As a clinician, I know how important it is to think of aortic dissection in patients who present with symptoms that could be compatible with it, such as chest pain and abdominal pain and back pain, for example, but also how difficult it is sometimes to diagnose. And we're here today at the Hull Royal Infirmary and we're going to speak to Austin Smithies and Lee Norman. In 2022, they teamed up and collaborated with the Aortic Dissection Charitable Trust on some work improving the recognition of aortic dissection in the emergency department. And this work won the 2023 Health Services Journal Patient Safety Award. We're going to hear from Matt Hurwood, who's a paramedic in the Yorkshire Ambulance Service, about how he has taken this work into the pre-hospital setting. We're also going to hear from Martin Hilton and his experience of presenting to an emergency department with aortic dissection, on it being diagnosed and successfully treated, and how he made an excellent recovery. But first of all, we're going to hear from Pauline Latham, who very sadly lost her own son to aortic dissection, which was unfortunately missed in the emergency department.
Ben came into the hospital in the afternoon, I believe. It's difficult because he's not here to tell us exactly what happened, and nobody really knows why he came in. But he came in here and he was here, I think, for something over 4 hours. And the diagnosis was, because he couldn't remember why he'd gone in to the hospital, why he'd been brought in, he couldn't remember that at all. So they diagnosed him with transient amnesia. But on his way home that night, I talked to him coincidentally. I rang him and he said he couldn't remember why he'd gone into hospital. He just had no recollection at all. And actually, he joked about it because he was dyslexic and his memory wasn't brilliant. So as a little boy, he used to go upstairs and I'd say, do this, this and this. And he'd come down having done one because he couldn't remember the others. So he said, I'm going to trade on that for a long time, Mum, because, you know, this is real. I've been diagnosed with it. But also he said that his legs were tingling. And I didn't feel this was a good idea. And I just said to him, look, Ben, I think you should go back to the hospital. And he said, oh, Mum, I'm just so tired. I just want to go home to bed. He went home and they had some cheese and biscuits because he'd not eaten. But it was 11 o'clock at night by the time he got home. Went to bed, and obviously he died during the night. But the hospital had said, come back if you know better in the morning. And my concern was we had a pathologist and a coroner's report, and they told us he died from an aortic dissection, which none of us in the family had ever heard of. We had no idea what it was. But there's no reason for the coroner to tell the hospital. So it's very difficult, I believe, for hospitals to change and to get proper diagnosis if they don't know that somebody's died. Because if you send them home and say, come back the next day if you know better, and they don't come back, you're going to assume that they're better. But he wasn't better, he died. So I'm really pleased to hear that you are improving your processes, that you're working to make sure that no other families go through what we've gone through over the last 5 years.
Pauline, it's interesting when you say about making sure that no other families go through what you've gone through. Now, you will remember that you spoke at the Royal College of Emergency Medicine Study Day, which myself and Austin were at, and you told Ben's story very well, and you explained that it had been in Hull. And for us, it was key.
Yeah.
For us to hear your personal story was key, because I think it helped, for me personally, and probably for you, Austin, it helped us realise the wider cost of a misdiagnosis, which you do know, but when you talk to somebody, you know it in a different way.
Well,
Does that make sense?
I think so, because when you're just seeing people in the emergency department, you're going from one patient to the other patient to the other patient. You're really busy, and I accept that. And what happens is, I think, in a way, you can almost think there's just the patient, and we're dealing with that patient, that person at that time, which you are, and you have to have an incredibly agile mind to be able to do all the diagnoses that are happening. But there is a family behind that. And if Ben was still here, he'd be economically active, he'd be supporting his family, his wife wouldn't have to work full time to be able to support the children. And the pressures on the children, particularly when they're teenagers, are quite great because they've got, we've had COVID, which has been even worse, but GCSEs, A-levels, deciding what they're going to do in their future, but only with one parent, not the two that they're used to having. The very fact that you have listened and acknowledged that there's an issue and are improving it is going to help so many families who won't go through what we've gone through. And that's the whole point of the charity, is to improve the outcomes. It's not just about making sure you know about it, but it's improving the outcomes for the patients, because it isn't just a patient, it is the whole family.
I think it's quite a big public health problem. A large proportion of aortic dissections are missed, and those 2,000 a year of lives that could be saved, the number could be even greater than that.
We do need to tackle this, and I do believe that in this region now, with the work that you're doing, you will improve the outcomes of so many people. And I think my role is to try and make sure it's rolled out nationally, because I want to see far fewer deaths from aortic dissection, so that there's more expertise in the surgery. There are some amazing surgeons who do amazing jobs and do save a lot of lives when it's been diagnosed. So those who've never been diagnosed could have been saved.
Hello, Austin. Hello, Lee.
Hi.
Hello, Matt.
I wonder if you could start by you telling us a little bit about your motivations behind the project.
So it stemmed back to an incident when a man in his 40s came into our department severely unwell and sadly died of an aortic dissection. Now, he'd been sent home a few hours earlier because the diagnosis had been missed. So what we wanted to do is we wanted to create a really meaningful and robust response. Aortic dissection is something that has been missed in our department before, and we didn't want history to keep repeating itself. I was really frustrated because incidents were taking so long to investigate that often the opportunities for learning had been missed, staff had rotated elsewhere, and things had just repeated themselves. So I wanted to do something that was meaningful for the family and for the patient himself, and also something that I would want if it were my relative.
So at the beginning of the project, we attended a study day by Royal College of Emergency Medicine on aortic dissection. At that study day, part of it was a relative's perspective, and the MP Pauline Latham spoke at the study day and told us her sad story of losing her son to a misdiagnosed aortic dissection and how that had made her feel. And then she said, well, it wasn't down here in London, it was up in Hull. And Pauline didn't know that there was 3 of us sitting there on the study day listening to her from Hull. And obviously we didn't know that Pauline was going to say that. And that made it more real for us to listen to somebody's tragic story and know that it had occurred in our department. And that really cemented our decision that we wanted to make an improvement in our ED.
I think we felt quite accountable, and that this was happening again and again in our department. And we felt a degree of professional pride that we actually wanted to stop that from happening.
Yeah.
So what was it that you set out to achieve with this project, Austin?
So this is a really difficult and complex problem to measure and improve, because we see such low numbers of patients attending with aortic dissection. We wanted to create a vigilance amongst the team analogous to airport security, keeping out for the rare event of a bomb in a suitcase. We wanted to take a human factors approach. We teamed up with a safety scientist who had experience of working in high-risk industries. And our specific measurable aim was that we wanted to detect 7 presentations consecutively with aortic dissection within 4 hours of arrival to the department.
Quite a challenge. So how did you set about doing that within your department?
So there were 3 main things. So firstly, we wanted to address the culture in our department of how we respond to incidents. Secondly, we wanted a data-driven approach so that we could really understand the systemic factors. And thirdly, we wanted to implement a series of improvements and measure our outcome measures in response to that.
So Austin, tell me a bit more about how you went about changing the culture in the department.
Since the 90s, the NHS has strived to create a just culture, but clinicians on the front line still feel that they work in a blame culture that discourages learning and reflection. And so we used 4 principles. So firstly, learn, not blame. So if we'd concluded our investigation that it was an individual's error, we would have lost the opportunity for much more profound learning as a team. Secondly, take a systemic approach. So what that means is look at all the factors, look at all the data available to us to understand what's actually going on. Thirdly, we took a safety to approach. So what that means is that we have the ability to learn from everything. So the full range of outcomes. We're not just trying to learn when things go wrong, but we're actually learning when things go right as well, because sometimes there can be just as much to learn from those cases. And fourthly, and maybe most importantly, is to have an attitude of civility and respect to everyone involved in the investigation, including the clinicians, because an organisation that looks after people when they've made a mistake has the ability to learn, grow, heal and excel.
So how did you go about changing that in your department?
So we used the mortality meetings as a springboard. We'd invite other specialties and we would lay down those ground rules early in the meeting, and we would analyse the case with the perspective of why did those decisions make sense at the time and what is the normal practice for clinicians in our department.
Austin, you've talked about how you managed to change the culture in your own department. How do you suggest other departments go about doing this?
I think the first step is to lay down the principles of the cultural norms that you want to have, and you can lay that down in your mortality meetings when discussing cases. One thing that we did that other departments could use is if we noticed a theme or an incident that happened, we would link that to a quality improvement approach. And I really think that helps you to look at the whole situation rather than just focusing in on one individual event. So take a data-driven approach, match a quality improvement approach to your incidents that have happened, and use your mortality meetings to emphasise the principles of a just culture that you want to create for your team.
So the second part of your project, the second objective, Austin, was very much about looking at the data to see how that can improve your misdiagnosis rate. So tell me a bit more about how you went about that.
So firstly, we needed to identify cases. So we used incident reporting, departmental coding, mortality data, and we also asked the coroner if they'd had any cases found at post-mortem. Secondly, we conducted a case note review, and what we found there was that often the delayed and misdiagnoses, the clinician wasn't considering the diagnosis in the first place. They often weren't recognising important clinical features and risk factors, and sometimes they were falsely reassured by certain clinical findings like equal blood pressures on both arms. We monitored the number of CT aortograms that were being performed, and actually in the early stages these numbers were extremely low, indicating that clinicians weren't considering the diagnosis. We looked at the patient's journey and all the steps from arrival through to having their CT scan.
So once you'd looked at that, then what did you do in your department then to be able to make these changes?
So the first thing that we did was we invited the Aortic Dissection Charitable Trust to come to our department and deliver a teaching session about dissections, which was wonderful, very informative, and I would recommend anybody to invite them to do that. That kick-started our project in a really great positive way. And what was really important about it was we know in quality improvement, the person that delivers the message or who delivers the message makes a big difference to how the message is received and acted upon. And with it being the charity and there being personal stories, we think that made a bigger impact on our staff. We
had a morbidity and mortality meeting where we discussed dissections, just dissections, and we invited all our consultants to come. It was very well attended. And we think that that helped them to get on board. So getting our consultants on board with the could this be a dissection message made a huge difference, because if the consultant is in charge of the shift and he or she is thinking about a dissection, then the clinicians are all thinking about dissection. With every patient they ask him about, her about. We launched a bit of an information campaign right at the beginning. We have a safety brief twice a day in the department during the day, and we had our consultants mention it at the safety brief. Please don't forget about dissections, they're easy to miss. Again, because the consultants were on board, that worked really well. And we did a poster and a screensaver campaign, kind of littered the department with it. And we left them up for a month or two, and we know that after a while posters and screensavers are of limited value and can become invisible. So we took them down and then a couple of months later put them back up and kept going in that way. We ran education sessions for all different levels of clinician and targeted towards them, including the clinical practitioners, senior registrars, brand new F2s. And we placed aortic dissection into the induction teaching as well, because obviously when clinicians rotate into the department, they have their induction, and we made sure it was mentioned right at the very beginning of their rotation, so it was in their minds straight away. I think that the thing that we did that made a big difference was persistence. We kept going with the project. We delivered a message, everybody thought about aorta, and then we didn't want people to only think about aorta, so we let it settle down, and we just kept going and reminding people of the message. And I think that allowed Could This Be a Dissection to embed itself in our department's thinking in its proper place.
Well, that's a huge amount of work that you've done over a period of time there. Mm-hmm. So then, did you look at what effect all of that work has done to your misdiagnosis rate?
So one of the main differences that we made was that we reduced the time from clinicians seeing a patient to requesting the diagnostic scan from nearly 2 hours to just over half an hour. We had no cases of misdissection during our study period, compared to 2 out of 17 cases in the baseline. We saw a steady and sustained increase in the number of CT aortograms that had been requested. Interestingly, in our baseline period, we were seeing maybe 1 dissection every 2 months, but during the study period, we were seeing 1 every 2 weeks. So we saw a huge increase in incidence.
Well, that's quite a dramatic change, isn't it? Why do you think that might have been?
So it's difficult to say for certain, but it does raise the question, are we identifying cases of dissection that we would have missed and would never have been discovered previously? The 30-day survival in our study group was 67%, compared to 53% in our baseline group. Now, with such small numbers, we can't conclude that we have improved mortality. However, we would hope that earlier and improved diagnosis leads to improved outcomes and better survival rates.
Lee, I'm interested to know, does the department feel any different working in it now you've done all this work compared to how it did before?
Oh, completely, yes. I think there's a huge difference. So before the project, aortic dissection, we knew about it, but it wasn't really discussed. It was very rarely suggested as a diagnosis. And I think kind of the feeling was, it won't be. Whereas now, it's just routinely discussed, it's routinely suggested, it's routinely considered, and the feeling is, if I was to say to somebody, could this be a dissection? The answer would be, yes, it might be. So that's been a big difference, definitely.
So Lee, what are the next steps?
Well, we've just actually rolled out a aortic dissection pathway, which is a wonderfully useful tool for all the clinicians in the department who might have just thought, could this be a dissection? Oh, but what do I do? That's just been rolled out, and that we'll see how that goes, but we think it's going to be really useful. One thing we have identified is that although clinicians are considering aortic dissection much sooner than they were, there is still a delay from the patient arriving in the ED to them being picked up by a clinician. They're not getting picked up any faster. So we've just started some teaching with our triage nurses to teach them about aortic dissection and to give them a few signs to look out for, such as risk factors, clinical presentations. We didn't want to overwhelm people with information, but we wanted for our triage nurses particularly to have it on their radar as well. Similarly, we're about to start some work with the ambulance service to help paramedics consider, could this be a dissection, and possibly pre-alert the department as well. And I think we're going to integrate it into their BSc teaching and perhaps deliver some teaching sessions. And the final thing that we have noticed is that, again, clinicians are requesting CT aortograms, but there is often a delay between the request and the scan actually taking place. And so we want to find a way of prioritising aorta scans among all the other many scans that our radiologists have to deal with.
The other thing is we feel like we've had a huge amount of success, and we want to share that with other departments. So we are heading up the education task and finish group for the aortic dissection toolkit for the North Eastern Yorkshire. And as part of that, we want to use the same data-driven methodology. We want to provide education for all staff who come into contact with someone with aortic dissection from the pre-hospital environment all the way through to the post-operative and follow-up period. So we are going to be using our learning from this project to inform that wider regional spread.
Thank you so much, Lee and Austin, for sharing your tremendous work that you've done. It's a huge amount of work, and we can really see the impact that what you've done has done to your department. So thank you very much for sharing it with us.
Thanks very much, Matt.
Now we're going to meet Matt Hurwood. Matt's a paramedic with the Yorkshire Ambulance Service, and he's going to explain to us how he's taken Austin and Lee's work and moved it into the pre-hospital environment.
Thank you, Matt. So I think the first bit to pick up on really is to echo the issues that Austin and Lee have already raised around recognising aortic dissection. It's certainly not unique to see definitive care, and it's something that is part and parcel of our responsibility as well within the pre-hospital environment. So I think we've got to recognise that a large proportion of people with aortic dissection may never make it to hospital. So it's of paramount importance that we, as the UK Ambulance Service Trust and indeed our community partners as well, have a low threshold in terms of that recognition.
And what do you see as the next steps, Matt?
So I think moving forward, it's going to be about really reinforcing that educational provision and hitting home for people to have a low threshold around consideration of aortic dissection and indeed some of the malperfusion syndromes that we may see, which can be really quite subtle. In part of the pre-hospital environment, we do develop working diagnosis and indeed differential diagnoses as well. So I think in terms of that, it's really important that we communicate in a structured way to our in-hospital colleagues that if we do have a suspicion that it could be an aortic dissection or a malperfusion syndrome, that is communicated early and communicated effectively.
No, absolutely. And thank you so much for sharing all that work with us.
Thank you.
I was out running one day, middle of the afternoon. I was with my wife and doing some running. And funny enough, it was one of the best runs I'd had for some time. But all of a sudden felt just a strange sensation. It wasn't a pain as much. It was just, almost felt like a indigestion. And but it stopped me kind of in my tracks and didn't feel like I could run on, but wasn't experiencing pain. Managed to walk back most of the way, but towards the end of walking back, which was after about a mile or so, I was really starting to flag. So my wife called my daughter to come and pick us up. She got us back home. And it was only probably then, I think, that I started to realise something wasn't right. There was still no pain. But as I sat down, I just started to feel incredibly tired and got really sleepy. And I think my wife saw this at the same time. And I think about the same time I was saying to my wife, you might need to call somebody. She was already on the phone. And that started the chain of events, which seemed to happen really quickly. So within minutes, and I think even while my wife was on the phone, to the emergency services, we had a first responder turn up, which was amazing. We live fairly rurally, so he turned up. We knew him as well because he's from the same village, and he just did a few preliminary checks. He took the blood pressure and did a few other bits and pieces, but wasn't too conscious of what was happening at that point. But the paramedic team were there within 10 minutes, which was amazing. And I remember vaguely a conversation between the first responder and the paramedic, and almost like the first responder was sort of apologising a little bit, that he's saying, I've tried this, but here's the results. So, and I remember hearing him say, I don't think my equipment's working properly. And I think what he'd done was he was trying to get the blood pressure, which I guess at that point was fading pretty fast, or I guess looking quite different to how it should be. They carried out an ECG and pretty quickly said, yes, there's been a heart incident. And then they got me on a drip, and, you know, within sort of 5 minutes, I felt completely normal again. And that was the whole strange event, really, that there was no real pain. And you feel like a bit of a fraud, to be quite frank. So they said, right, we need to take you to hospital because there has been an event. Straight in, and very quickly, a series of scans. So starting with an ultrasound from a cardiologist, and he carried out that, and you know, just chatting away as they do. And he went away then, and then came back, and he said, yeah, the results, couldn't quite see them, so I'm going to do it again. And then he went away again, and then came back with someone else. And I started to realise that there was a little bit of code going on, that this was pretty serious. And because initially it was kind of assumed that I'd had a heart attack, which was quite a shock, really, because I was a pretty fit guy. And but after the third one, where it had been confirmed on the ultrasound, he used the words, which I find quite humorous now, as I did then, to be honest. He kind of said, oh, unfortunately, it wasn't a heart attack. And that was kind of bizarre, because a heart attack for me at that point was just being like, that's just catastrophe. So it's kind of like, Christ, what is this? If this is worse than a heart attack. And that was the first time I'd heard about aortic dissection. So I didn't know too much about it at all. And then a CT scan followed, and pretty soon afterwards, packed off to the local heart centre and into the operation. It's all a bit scary in retrospect, but I think the way it was dealt with, both in terms of the speed, which I think from kind of my incident to going into surgery was round about 8 to 9 hours, which I suppose to me as a layperson feels like a long time, but really reflecting and obviously learning some of the medical elements, it's no time at all, really. It took a little bit of time to sort of trust the system again, and I think the whole new system I've got, because I had quite a lot of bits taken away and replaced, so a new arch, new valve, pacemaker and bits and pieces. So I guess that took a little time to sort of bed in, but now I'm, you know, back running, back swimming, back cycling, doing events. I've reflected really that it must be so hard to look at somebody who is internally very, very seriously poorly, but outwardly doesn't show any symptoms. There were, you know, I didn't have my arm hanging off or anything crazy like that. So I think it's really important that people are aware of the process and that clinical process and the good practice that clearly I experienced and that's happening in pockets around the country. You know, for me as a non-clinician and not being involved, and I'm more in the sort of private sector on business, that's what needs to happen. Good practice and best practice needs to be spread, and it's easy for me to think this is, you know, aortic dissection and it's the most important, but there's lots of things. But if aortic dissection, the condition, can be up there with clinicians as a front option when some of these symptoms are being picked up, then clearly that's going to be good.
We've heard today about some of the excellent improvement work that's been carried out here in Hurwood Infirmary, about how we can change culture, we can look at our data, and we can change our processes within the department in order to better increase awareness and hopefully increase the diagnosis of aortic dissection in the emergency department. And hopefully you will have taken something away from this that you can apply to your own emergency departments. We know that if we detect aortic dissection early and we treat it, that it's a very survivable condition, and it's important we strive to improve awareness and also the care of patients who present with it to our emergency departments.